So hello, I am Isabel Olivera. I work for EHA Education, and we have the pleasure today to have with us Dr. Fioredda and Professor Papadaki, who are going to be talking with us about autoimmune neutropenias. Can you please introduce yourselves?
Okay, my name is Francesca Fioredda, and I am a pediatric hematologist. I've been interested, I work in a pediatric hospital, one of the three major hospitals in Italy, and I've been involved in bone marrow failure and neutropenia since 2000.
Thank you. So I'm Helen Papadaki, or Helen Papadaki, and I'm professor of hematology at the University of Greece. I'm the chair of the Department of Hematology and also of the research lab. And currently, I'm also the chair of the Human Cost Initiative, which is a large project that implicates any type of neutropenia every time.
So we're going to be talking today about autoimmune neutropenias, and we want to have an update on the latest findings about this disease. Can you begin, please, by explaining what autoimmune neutropenia is and how it's defined in a clinical setting?
Yes, autoimmune neutropenia is a reduction of absolute neutrophil count for children below 1,500, and which is chronic, lasting more than 3 months, and which is correlated with the presence of antibodies against neutrophils. We believe that the mechanism is mainly due to the antibodies, but we can also speculate some more other mechanisms.
It's the same in adults. However, we use a little bit upper limit as an upper count as a lower limit, 1,800, according to the WHO. Otherwise, the term is the same. And however, in adults, we have to keep in mind that there are not only antibodies that may result in neutropenia, which is the traditional way. However, there may be also cellular mechanisms, which means activated T lymphocytes or natural killer cells. So this is the slight difference between the children and adults, that in adults we have more often cellular mechanisms compared to the children.
And with this definition, do you think that many cases of autoimmune neutropenias are being missed, or is this a good enough definition?
Yes, I gave the definition of autoimmune neutropenia because of the presence of antibody, but we all know the pitfalls of this test, because you can find this test negative for a number of times during the follow-up, and in this case you define neutropenia as idiopathic, which is a nosographic entity quite comparable with the autoimmune one. And as Helen told before, also in children there are some supposed cellular mechanisms that can contribute to the neutropenia. So the division between the autoimmune and idiopathic is slightly nosographic, but sometimes, at least in children, they are the same disorders in a way.
So you have been highlighting the difference between children and adults. Can you please explain further what the difference between this disease, the presentation in children and in adults is?
So we know very well that both neutropenias, with and without antibodies, that present very early to life, may resolve at least in the majority of cases. In these children, the disorder is quite mild, and we observe the resolution. But we have some cases lasts, and this is a connection with the adult world.
I think, yes, actually in adults, in contrast to children, where autoimmune neutropenia is a very common diagnosis, particularly in small children. And this is actually a mild form of disorder that resolves automatically. In adults, First of all, they are underdiagnosed, given that traditionally hematologists think that autoimmune neutropenia is related always to anti-neutrophil antibodies, and the diagnostic test is very difficult to be performed in traditional laboratories. So sometimes the hematologists in adults do not send this test to the laboratories, whereas on the other hand, they do not have in mind that also cellular mechanisms may be implicated. So in adults, given the rarity of this disease, yes, it is underdiagnosed. So this is a difference between the two age groups. And also, we have to keep in mind that in adults, the diagnosis of autoimmune neutropenia might be just the tip of the iceberg, because sometimes another disease is underlying, either a systemic autoimmune disease that do not present with the typical symptoms and signs. So another disease may be there and may result in the production of antibodies or the presence of activated lymphocytes. Or sometimes, which is, of course is not so common, there might be a congenital disorder that has not, congenital immunodeficiency disorder, which might be mild and has not given symptoms and signs until the adulthood. So I believe that, and I'm totally convinced, because we have in our control many neutropenia patients, and I know that many cases are underdiagnosed, and in case that we finally give this diagnosis, we have to very broadly investigate the patient for an underlying disease.
Yes, thanks to our collaboration, we found a point of connection between children and adults, because those forms that do not have remission within 36 months, usually, as the literature says, may last for a long time, and sometimes these patients, being mild phenotypically expressed, may not be diagnosed. So I can find a 14 years old, for example, girl or boy with neutropenia and never diagnosed before, or probably Helen may find an adult, a young adult with neutropenia never diagnosed before. And so we think that their neutropenia in these cases began very early in life, but we did not able to diagnose it because it was because it did not show any symptoms. And so when I say connection, I mean this fact. And in our study that conducted in long-lasting neutropenia or late onset, we found a number of genes of immune dysregulation. That was the phenomenon that Helen cited before. So the neutropenia is an aspect of something that is going on down, and it is probably, there is a possibility that it develops in something else, by showing some autoimmune signs that may be diagnosed later as known immunological or autoimmune disorders.
So the mechanisms of pathogenesis are different in the cases in children that dissolve spontaneously than the ones that last.
In children, it has been seen, for example, in preterm babies, who the immune system is immature for definition, maybe something like an inability to fight the autoimmune responses, and probably once you have gained the ability to respond, the neutropenia resolves. It is only an hypothesis. Otherwise, if there is a defect, which is a congenital defect of answers against self-antigen, all the things are different, I thought.
Yes, and in adults, whenever we have to investigate a patient that comes for neutropenia, for the with the diagnosis of neutropenia. Of course, we, among others, we perform the anti-neutropenia antibody testing. However, when it is positive, we do not relax, because this is the difference between adults and children. When we have the presence of anti-neutropenia antibodies in an adult patient, we have to explore why. Is there any underlying disease? Is there any systemic disease there? Or is there any drug that might be implicated? Sometimes patients forget to mention drugs such as natural supplements or, over-the-counter drugs. So you have to take a very careful medical history in order to exclude this possibility. On the other hand, except the anti-neutropenia antibodies, we always perform a flow cytometric analysis, very simple flow cytometric analysis, to identify the possible involvement of T cells or natural killer cells in the neutropenia. And when we have such populations, we have again to explore if there is any underlying disease. And further to what Francesca said, in adult cases that we find, you may have very subtle abnormalities such as a little bit low immunoglobulin levels or some immune disturbances in the B or T cell populations. Then we have to check for congenital immunodeficiencies. So perhaps there is, as Francesca said, in some cases, perhaps there is some congenital basis, and we have this continuation from the late onset neutropenia in children into the adult neutropenia. So it's very interesting for us, and this is the importance to have registries of patients in order to explore the metagenetic basis and the cellular clinical characteristics.
Yes, and if I can add, Helen did some elegant experiment on bone marrow in which she showed that there is an inflammatory and a production of a negative cytokine that may affect the granulopoiesis, and this is probably one of the mechanisms that is underlying, and it is promoted by the presence or the absence of some class of B subpopulation and T subpopulation. We are going to observe a characteristic pattern in these patients I mentioned before, the long-lasting and the late onset, in which there are a defective in the switch of B cells, and there is a terminal effector strange action within the marrow, within the blood that can justify and sustain all the mechanisms. So we had to go surely further to demonstrate also in an adult the typical subpopulation pattern that can sustain all the stuff.
And how to treat autoimmune neutropenia in the different cases? Are there different treatments depending on the mechanisms that are underlying, or?
This is a very nice question and a very interesting question, because actually we do not treat, neutropenias. We treat patients, and regardless the neutrophil counts, if the patient is well and do not have, particularly in adults, but it's also similar to children, if the patient does not have infections, and of course I'm stressing the fact that we have to exclude that other disease, because if we identify, for example, neutropenia in the setting of systemic disease, we have to treat the systemic disease. But in cases that we have what we call prime embodied idiopathic autoimmune neutropenia, if the patient does not have any infections, we do not treat the patients, because otherwise we should give, for example, corticosteroids or the other medications that suppress the lymphoid system, and perhaps the benefits would be much lower than much lower than the harmless. So we do not treat the patients if in primary autoimmune neutropenias in adults if the patient does not have infections. If the patient has infection, we may try with very small doses of G-CSF, because usually, given that the bone marrow is usually normal in primary autoimmune neutropenia, the patients respond with very tiny doses of G-CSF. So, to summarize, when we have a primary autoimmune neutropenia, we do not treat if the patient does not have any problems, particularly infections, and if he or she has infections, we treat with very tiny doses of G-CSF. If autoimmune neutropenia is the result of a systemic disease or a distal disorder, etc., we have to focus on the underlying disease.
Yes, I'm really in a similar mood, and I can underline two things in children. The first is that in 90% the clinical picture is mild, and they do not need our treatment. But if there are a little portion, from 10 to 12%, according to the literature, in which neutropenia has a severe picture. For example, a lot of children presented to us with otitis and mastoiditis, and for example, the palsy of the 7th pair of nerves, which is quite severe, or perianal abscess. And in these cases, we have to treat neutropenia in order to clear infection and to be sure that the infection is clear at all. Because, for example, the recurrence of otitis can give some persistent damage to internal air. And so these are the points. We must have attention regarding the sign in a little portion. And in those cases, this is the second concept, we have to do a very attentive differential diagnosis with the congenital form, because they can mimic in some way, in some little part, a congenital form. So sometimes we are not able to distinguish at the beginning of the diagnosis, but we have to follow the child until he or she reach the remission, or until we have some more data on, for example, bone marrow or genetics that help us to distinguish the two forms. So not for all, it's a benign form, to summarize, and the thing is try to distinguish which kind of neutropenia we are facing with. So,
and in the cases of both children and adults where the case is mild and the neutropenia is there, but you don't treat it, will you follow these patients a long time to see if something happens? Will you follow the history and see if they never need a treatment, or how much do you need to keep an eye on them?
You know, idiopathic, as we always do, in what we call idiopathic in medicine, it actually means that we do not know what happens there, and we do not have any diagnosis there. So idiopathic is an exclusion diagnosis, and therefore, whenever in adults have this diagnosis, primary or idiopathic autoimmune neutropenia, even though the patient does not need any treatment. However, we have to very carefully follow up this patient, have to follow up with these patients, just in case to develop any other disease. So yes, we have to have a very careful follow-up with this patient in order to exclude any other disease that did not come out from the beginning.
Yes, also in children, the significance of following them is, first of all, to intercept the moment in which the neutropenia remains, which is the first goal. In the cases without remission, we follow them, and we have learned a lot from adults. Try to do the least exam as possible in period every 3-4 months, and not so frequent, in order not to have some torture yes, yes,
for the patient.
yes, that's because sometimes it's the family that complain for
It's too much for the patient,
yes,
for the family.
yes, and we have learned also that in some cases we have not repeated the bone marrow, for example. We have discussed a lot on this stuff, mainly in those patients that have their peripheral blood count stable. And so probably what we can do is to deepen the immunological aspect in those classes that do not permit, and also to apply the genetics test that are going more and more specific for these kind of disorders and sensible.
Thank you very much for your time, for your availability.
Thank you.
Yes,
It's a pleasure.
It's a pleasure.